Well, good morning, everybody. It's good to see everybody in here, so many familiar faces, and perhaps familiar because you've already been involved in the quality assurance or in the quality improvement aspects of our programme. And if you haven't been, hopefully you'll know a little bit more about it in the next 20 minutes or so. My name's Matt. I'm the Quality Improvements Project Manager. I lead on the Quality Improvement Collaborative. I'm joined by my colleague Heather.
Hi, I'm Heather Clark. I'm the Project Manager for the Quality Assurance Workstream, and I'll be speaking to you in a moment.
Now, the quality programme is split up into two parts, so quality assurance and quality improvements. And who's got the toughest job? I don't know, but we might find out by the end of the next 20 minutes. So without further ado, I'll hand you over to Heather, who's going to just give, we'll have 10 minutes each, just giving you a reflection, an introduction, and a summary of how things have kind of gone over the last couple of years.
Thank you. Okay, so as I'm sure many of you know all the background to this, so I'm really not going to spend too much time on that. But just for anybody who's not aware, so the Diabetes Quality Programme is a 3-year national programme which commenced in April 2018. We've recently had an extension for an extra 6 months, which takes us until the end of August 2021. As Russell mentioned earlier, we've got just over 90% of paediatric diabetes units across England and Wales signed up, and it combines the quality assurance and the quality improvement work streams. We've got a small map here which shows you the participation of each unit within the programme, broken down on a regional basis, so hopefully you can see your units in there and your colleagues. The quality assurance workstream in itself consists of 3 elements. We've got the annual self-assessment, which I'm sure you're familiar with, which combines 120 elements across 33 measures in health board and hospital trust measures and MDT measures. That's supported by an external verification of the documentation with a small selection of teams each year. So essentially, we select you to make sure that the evidence that you are able to provide supports the self-assessment that is submitted annually. That's just to ensure that we're all on the same understanding of what's required and what we're looking at. And then we also have 1 peer review visit to each unit within the programme. I'm going to outline some of the successes and challenges we've seen when we're visiting you. Again, I'm sure none of these are a surprise to you, but we thought we'd show you some of the main themes. The one thing that comes across in every single visit, time and time again, is how much the teams value each other, and it's a strong element throughout the day. Within all the individual interviews, we speak to team members separately and together. We speak to parent representatives, we speak to trust managers and CCG representatives. The wealth of information about how much you appreciate the work that you each do, the stories of the way that you're pulling together a team through difficult times for whatever reason, is always very, very valuable to hear, and the way that you speak so highly of each other. In particular, we have heard amazing stories of the way in which your team coordinators or administrative staff support you and underpin so much of the development, and it makes such a difference. We can see in the way that you talk and the ideas that you have for those teams that have them and how those that don't. It's really important that we would encourage you. I know some of the administrative teams are here today, so to just celebrate those people and the work that they do, underpinning the data analysis that's becoming ever more important, making everything run smoothly and in its own way, relieving that burden on the rest of the staff. And also we've heard in terms of the personal support that they can give. In terms of the use of BPT, since that's been established, we've heard so many different ways that people have used that. In particular, in terms of a skill mix, and we've heard a little bit about it today, how you're bringing in other interagency workers from youth workers and clinical support workers, and also some excellent, strong relationships with dedicated adult colleagues who are facing their own pressures, but they're still sort of spending a lot of time to help get the transition services up and running with as much passion as well. Where it has been possible, we've seen some really interesting and innovative ways that you're implementing transition clinics. And as a team, when we go around, as I say, we speak to the parents as well as the services. And we ask you about what you're doing for children and young people. And that personalisation of care, some of the personal stories and the way in which teams have perhaps run quiet clinics or including the siblings or pictorial guides for anybody, really appreciating what it is the child and family are bringing and how you can best adapt. That person focus has really shone through. A lot of teams have spoken about how they're really getting out of the clinic setting, again, in recognition of that, looking at the ways they might use the other resources available. So drop-ins in school, clinics in schools, particularly youth centre works and things like that. So many teams talk about the wide areas that they're covering, but the resources that are available out there in the community. And finally, time and time again, we hear the same examples. People are so enthusiastic about taking in the ideas and the inspiration that they've heard from colleagues and bringing that into their own services and adapting that and implementing it for them. So it's really great to see some of that spread of information and ideas that goes across both your regional network but also your other networks that you have and the openness of developing. I'm going to very quickly go through these challenges because I'm sure nothing is a surprise. Transition and psychology really do come up as those areas that teams are struggling with capacity and time. Capacity across the MDT, the burden of travel, some of the gaps covering colleagues' gaps, and dealing with some of the increasing expectations of some of the patients and families that you see. IT infrastructure across the board, access to Wi-Fi, which makes everyday tasks quite difficult and frustrating, working across different systems because you're different disciplines or perhaps different trusts, and simple things like remote working and availability of PCs, enough PCs for everybody. It's been quite disappointing how few people have good access to specialist training, funding opportunities, and the support that you get through some of the sort of trust boards to access that, and not just additional training, but really that core specialist training. An increasing administrative workload in relation to technologies and processing the contracts and that side of things. Clinic space, office space, just getting that right balance, that right mix. And again, it's really clear when we're talking to people where you are able to share an office, a space, those informal communications against the formal ones make such a difference to the teams. We heard earlier from Justin about the structured education, and we are seeing so many people have excellent programs at the beginning, but we often hear that people are really pleased with how it's going, but catching up with those patients who may not have experienced good structured education in the early years for whatever reason, and helping the young people through the particularly difficult times later on puts huge demands on some of your time. And finally, just the increasing complexity and need that you're seeing within your populations, the demands on your time, and that because you're the person that the families turn to, regardless of what's going on, and you do offer that support, it just pulls further burdens outside of your specialism on your time and also your emotional capacity as well. We hear that quite a lot, how much you want to do the absolute best across everything outside of the core diabetes work. Going to spend a little bit of time just as a team, what we've taken from that and some of our reflections. It's just been a huge steep learning curve for us as a team, and seeing our colleagues grow in their knowledge and skills and appreciation for what you do as we go out. So after every visit we come back and we talk about some of the themes, partly to keep that consistency, but to help each other identify for next time how we can keep it going. And that really is something that's been quite beneficial to us. It's been really encouraging that despite the difficult messages we are sharing at the end of the day with some of you and some of your senior managers in terms of serious concerns that we have to raise, it can be difficult, but the way in which the reviewers really take that on board, the responsibility that they take on to make sure that that's right for everybody, and how everybody within the teams that we're speaking to and the trust managers have taken that on constructively to take it on board and progress to improve things further. It's been very helpful. We've heard quite a lot of times that it's offered you the opportunity to be heard because there's so many conflicting priorities and everything's happening. It's just giving you that time together to be heard, to think about it and to move on and raise your profile. Essentially the enthusiasm that we hear in every time that we speak to people as to what they'd like to share and spread with others, and just their desire to get the message out there. From my perspective, in terms of the reviewers that we see, there's been fantastic development and growth, and when we get feedback we talk about people going on the first visit and it's been very positive and enjoyable, but they talk about how the second time they've been able to refine that and particularly growing confidence, asking the right questions, getting the right information, and it's also enabled people to take that back to their own services, so it's perhaps given them the confidence to speak to their senior managers if they need to in a different way using the correct terminology and being able to push for what they need, and it's also enabled them to have that framework and that reference to come back to give them better arguments when developing their business cases. One of the strengths is just that the objectivity that you bring as reviewers and a pragmatic approach, having been there, seen that, and trying to formulate that into something that will work and is pragmatic and it's feasible, and it might help the service. That's been very encouraging. And particularly when we're speaking to our parents and the representatives and some of the young people, they always talk about the warmth with which they're received, the availability of the teams, regardless, day or night, 3 a.m. you're there, the patience, particularly in the early days. The phrase I've put here is one that we've heard in pretty much every visit. Nothing is ever too much. Everybody is always there. I think it's also important to recognise that they recognise the pressures that you're under. So whenever we do hear anything that's negative, the parent representatives are always very keen to say, but I know how busy they are, or I know how stretched they are, and so I don't feel that I should be telling you. So we do encourage them from a perspective of it's to help, and we will do our best, and everybody understands. And it's very motivating just to see that drive and energising to keep us pushing through when we come back with some of these examples and stories, and this, in terms of being a critical friend, trying to help push everything through. I'm going to leave on some examples. As I said, there's all those big things. We know you can do some excellent things with transition and education, but it does require money, and that's not always available. It requires time, people. It's not always easily available. One thing we really want to show from what we're doing is the small things that make a big difference. Now, this is a quote that we've heard from half a dozen services as we've gone round. They're really keen to show what small things they've done that have saved them time, that have helped them bond and develop. So some of the key examples that we've picked out. So the annual review taking place on coloured paper if you are paper-based records, so you can very quickly and easily see what's there. Rotating the chair of the NDT, I'm sure many of you do that, but that's definitely sort of helped people to each take responsibility and develop services and have a voice within their team. Encouraging patients to take a photograph of their care plans. They've always got a copy with them. This is a picture of a board that we saw that's got them mnemonic to go through and to help everybody learn those key messages when they're on the ward. And finally, this is a bit of a paraphrase, and I know a couple of you in here have said similar, so it is a combination. But in terms of the visit, when we're kind of talking at the end of the day, people said, we've been talking to our colleagues here and here. We just wanted to show what we could do. Perhaps we didn't ask for help as early as we could have done, but this has given us the time, the opportunity, the togetherness to be able to do that. Finally, I'd just like to leave you with one quote and question from one of our peer reviewers. So we heard amazing stories. We were sitting with the trust representatives, and we heard some fantastic stories about the achievements of the team. We moved on from the list of achievements to their more personal reflections on how great the team were, and our peer reviewer said, that is amazing, that's fantastic. Now, have you told them? And we'd just like to encourage you to keep doing that, so make sure that you're telling your colleagues when you do receive that feedback. It made such a difference for the team at the end of the day to hear what the trust managers genuinely felt, so we'd just like to encourage you to keep spreading that message about how much you do and how much it is appreciated. So if I could take that moment, and on that note, hand you back over to my colleague, Matt.
Thank you, Heather. And very rudely, earlier, I'd not introduced Megan, who's a quality improvement project manager at the college, and Megan's in demand speaking at other conferences before this. So I'm relieved that Megan's turned up to be rounding off the last part of this presentation. So my job now is just to kind of give you an update as to what the QI collaborative is, and it's something that I've heard already from the other speakers and already have an idea of what it's about. Can I get a show of hands, please? Just those who have either been through the collaborative or are currently in there already. A lot more than I thought. So altogether, 33 teams have been through already, and there are currently 23 teams actually going through the collaborative as it is at the moment. And it's split up into 4 training sessions. So we have 4 sessions, each 3 months apart, and they're done regionally. So between, let's say, between 6 to 10 teams within a region will take part within a certain time. And teams receive training on QI methods, QI coaching, and will also start delivering and start on quality improvement projects of their own. As you can just see here throughout, we started off with the pilot in 2017. That was waves 1 to 3, and that was done nationally. So following a successful pilot and with some good feedback from that, they've been run regionally since then. So started off in Exeter back in March, and the ones that have been through their been through the collaborative journey already, Exeter, Manchester. Bristol, those who are currently in the process, Bristol, Winchester, Darlington, and we've got Cambridge, Sheffield, Birmingham or Leicester yet to come up, and applications will be opening up for those shortly. So where do we start? A good place to start would be just to give you an idea, a snapshot of the kind of the collaborative aspect of the program. And these are, as you can see, there's no individuals in these at all, and no selfies. The collaborative aspect is a really important part of the program because we invite whole teams to apply, and the really meaningful kind of QI collaborative work can really be done with a whole team and also individuals. Sorry if you've just appeared in those. We've picked those up, and I hope it gets across also kind of the positivity of what the collaborative's about. Now, what do we actually cover during the meetings? QI tools would be one area. Get teams started off in getting used to using diagrams, fishbone diagrams, driver diagrams, ways of being able to, whole teams being able to analyze, really get to know their service and to start thinking of quality improvements, ideas of their own. Moving on to methodology, and hopefully you don't get too bogged down in terms like statistics and formulas and things like that. Some people, that's fine. I'm personally not a big fan of that, so try to keep things as simple as possible. And QI measurement, a measurement for QI, doesn't have to be that complicated. And we've got a system here whereby dry pasta has been thrown into 2 plastic cups in order to kind of answer a question. Just give us an idea of whether a change idea is working or not. And if it is working, great, let's start to move that on a larger scale and expand that. If it's not working, let's just move on. We fail fast, we think about something else. A number of teams have also put up, as you can see on the left-hand diagram there, in staff rooms, just that graphs just recording things such as HbA1c levels and DNA levels on a daily basis. So a real focus on kind of quick and simple ways of being able to collect information. By the end of the collaborative, and I'm glad that we've got colleagues here today from Torbay, I understand, who have been part of the collaborative already, and giving us an idea of their journey and their reflections on that. Here we've got a couple of posters from Derbyshire Children's Hospital and Alderhay. And by the end of the programme, by that 4th session, teams would have already had a great deal of dedicated team time, would have had coaching over the phone, and we've been through 4 different sessions already, and have already started to make improvements, recognisable improvements to their service. We also use this as a springboard as well, so not only has the collaborative ended, the journey continues to really embed quality improvement in services. We use these as motivators as well in motivating teams to improve outcomes for young people and the children and young people that we work with, and what better motivator do we need than that? A couple of dates we'd like you to keep in your diary if you're not aware of those already. On my side, on the quality improvement side, we have applications opening for Wave 9 Cambridge. They are open already. You may be able to download an application form if you have a team that is wanting to be engaged in quality improvement. I'll be here all day. Please come and approach me if you'd like any more information on that. And application forms are available on the internet there as well. Heather?
So I know many of you are already signed up as peer reviewers, but for anybody who's not and who's participating in the programme, we have what's likely to be our final session. That's taking place on the 10th of February in London. So do let me know if you'd like an application form to be sent to you.
We hope altogether that's given you a good idea of a lot of the work that's been going on over the last couple of years in the within our team, within our areas of work. So we look forward to being able to work with you throughout the day. I'll hand you over to Megan now, who'll just round off the rest of the presentation. Thank you.
Hi guys, I know I'm eating into your tea and coffee time, but it's up to me to round things off. So 2 years ago, pretty much exactly to this date, Fiona, I sat in a meeting room in the London offices of RCPCH and I met Dr. Fiona Campbell. And I had left paediatric training and I thought I was going into a 6-month placement to coordinate some quality improvement national initiatives. And so I was learning about the pilot diabetes collaborative and I thought, okay, 10 teams, pilot QI collaborative. 2 months later, I was sitting in front of the London Regional Network meeting, talking about how profound it could be if this was a national quality improvement collaborative. And so fast forward 2 years later, and we are in the middle of a national quality program. So it's been fantastic to kind of see that journey and live that journey over the last couple of years. And it's great to be able to hand over to Matt to take the reins for the quality improvement collaborative side of things. But I just wanted to give you a few reflections of my own about what I've seen out there in our paediatric diabetes community. I've seen you guys break through your hierarchical structures and actually be a team and be a living embodiment of everyone's business is improvement, and improvement is everyone's business. I've seen you guys take a data-centered approach to look at what needs improving, but then actually combine that with a person-centered and family-centered approach to look at how you can improve. And that's been incredibly inspiring. That has taken you guys to all over the world, and that has inspired collaboratives in the diabetes community all over the world. And you've got some stuff from T1D exchange happening, and we saw some really great outcomes from a pilot in Norway at ISPAD. I've just come from a specialty meeting of paediatric palliative care and looking at how quality improvement could help support that specialty group. And I realise that I'm standing in front of you with a lanyard on my staff badge, and it's a lanyard for the Epilepsy Quality Improvement Programme. I'm sorry, but... But in November last year, we launched the pilot Epilepsy Quality Improvement Collaborative. So this last couple of years, as well as the outcomes that we'll see, you've also inspired a whole other body of work and a whole other movement, and that's beyond diabetes, and it's beyond the UK. So thank you.